Hello, good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I'd like to welcome you all to today's live panel discussion that's hosted by Proficient Health, titled 2020 Redirected, a fireside chat with ACO leaders on the impact, the comeback, and the future for accountable care organizations. Obviously, there's a lot to discuss here, so we'll jump in very soon. A couple items of housekeeping before we get started. Everyone who has joined as an attendee has joined in listen-only mode, so the microphone is already muted for you. You don't have to worry about doing that. Also, the webinar is being recorded, so you will be able to rewatch the session and or share it with colleagues. We hope that you do. And I will be emailing you all a link after the presentation that will have a link to the recording and also where you can download these slides that are associated with it. Finally, we want to hear from you. So during the webinar, you will have the opportunity to ask questions using your attendee control panel. There's a little module, a question module. So you can submit questions there anytime. You don't have to wait till the Q&A at the end in order to do so. And we're going to try to get to as many of those as we can today. But for those who were not able to get to, then we will make sure to follow up via email afterwards. So we've got a lot to discuss today, so we'll get to as many of those as we can. All right, so without further ado, let me introduce our panel here. Sitting on our panel today, we've got Matt Butala, who's the Assistant Director of Practice Performance at Triad Healthcare Network. We've got Dr. Brian Klausner, who's the Medical Director for Wake Key Community Care, and Mr. Tyler Wilson, the VP of Population Health with Austin Regional Clinic. Our moderator today is Dr. David Hoover, who's the Chief Medical Officer with Proficient Health. So, and he is going to be kicking it off for us. So I'm going to hand it over to you, Dr. Hoover. Welcome.
All right, thanks, Garrett, and welcome to everybody. We're so glad y'all are taking the time to spend some time with us today. We are so pleased to be able to host this at Proficient Health. Our tagline is the communication behind the care. And we really believe, as our mission statement says, that we can improve care by facilitating better communication in multiple different modes. We all know the problems that exist with multiple EHRs and disparate systems. And at Proficient Health, we have a variety of applications that help bridge those gaps and enable providers to communicate better, provide better care. And we work a lot with hospitals, we work with ACOs, and so we're really excited to be able to bring together some key leaders within some very large ACOs. We were just talking between the three of them, there's 750,000 covered lives, and $3 billion worth of care that's going on amongst their entities. And so as we work with different entities like these, we partner along with them, coming beside them in a different variety of different type of applications to help facilitate better care. And so that's what we do at Proficient, and we want to go ahead and get right into the webinar. So the first thing I'm going to do is just ask everybody, once we go through, you can just see from, the value and benefits. We're just sort of scrolling through this really quickly, but if there's any, the net of it is, if you have some interest, we'd love to talk to you about what we do and how we can help with your individual ACO. But we're really here today just to hear from these three leaders and to see what's the future of the ACOs, with what's going on with everything with COVID and how things have changed. So we'll get right into it. And the first thing we'll do is let each one introduce themselves, and we'll turn it over to Matt. And then it'll be Dr. Klausner, and then we will go to Tyler. So Matt, if you could just give us your name, a brief organizational history, and then we'll get into some questions.
Okay, yeah, thanks, Dr. Hoover. And again, my name is Matt Butala. I'm the Assistant Director of Practice Performance for THN, and I had a couple of firsts today. One, this is the first time I've been in my actual office in 3 to 4 months. First time I've shaved my head and my beard. I was starting to look like Tom Hanks from Castaway, so my wife is is quite happy. She was beginning to stop coming into my office at home and see me, so I was a bit concerned. So it's been a transition, to say the least. The areas that I'm responsible for at THN are really practice performance, engagement, network fidelity, system margin, care variation, referral management, physician incentive, all of those kind of things. And you can go to the next slide. THN really got its start in 2014, and we started as a MSSP, and we've transitioned into next gen. But as you'll see from this map, we have a bit of a unique situation, and no offense to academic medical centers, because there's definitely a need for those centers. For example, we don't treat burns. We don't do transplants here in Greensboro, but you'll see us in the middle, sandwiched right between Wake Forest Baptist Health and UNC and Duke. So clearly, network fidelity for us is a big part of what we're trying to do, keep those patients at home, because for nothing else, a lot of the care we can do here, and we think we can do really good quality care, but then the DRG cost that goes along with it. So go to the next slide. These are the amount of covered lives that we have, and as you can see, most of the MA, or all of the MA contracts rather, are in some sort of a full risk agreement. A couple of years ago, we started to dip our toe into the commercial space, which is a whole other challenge, just as you all know, the way that those contracts work and the complexity of them. But all in, we have about 190,000 covered lives across THN. You can go to the next slide. As far as incentives, what we've been able to provide back to our physicians in 2014, obviously we started with $3 million, and as the years have progressed, we've really learned how to get good at this quote unquote game. This year we have a proposed about $9 million that we're going to distribute to our 12 to 1400 MD and DO physician members of THN. So we're really excited about that, and we're sort of projecting over the next few years to double and triple that amount through different initiatives that we're doing. So thanks for including me. Happy to participate, happy to take questions, and turn it back over.
Brian.
So thank you for having me. My name is Brian Klausner. I'm a primary care physician for Wake Med and for our ACO WKCC. And I work with a lot of our population health efforts as well in regards to, we're in a state in North Carolina without Medicaid expansion. So we've developed some population health models for our uninsured, for our homeless, and for some with a specific focus on behavioral health. So our ACO is kind of this cool partnership between Wake Med, which is kind of our community hospital here in Raleigh, and then over 350 independent primary care physicians. And you can see there our mission statement to deliver high quality, high value care, which I know sounds like a lot of different mission statements across the country, but something that we really take seriously and have been doing now for over 7 years. So if you go to the next slide here. So a little bit more about the two partners. So it's really, two become one with this ACO. So Wake Med, a private nonprofit healthcare organization in Raleigh, 941 beds, locally based and community owned. And then our key physicians who, just this incredible group of primary care docs who over the years have just done a tremendous job clinically, really did a fantastic job pre-ACO, kind of at the patient-centered medical home model through NCQA, a lot of the amazing work that they did with that. And so we were in a good opportunity to come together and do some cool stuff with value-based care. You can see the stats here. We're about 220,000 from a patient coverage perspective. We have 750, we have a high value specialist organization, 750 high value specialists in that group. And we are, last time we checked, last year, the 16th largest ACO in the nation. So one of our challenges, honestly, is historically we've been pretty successful. So one of our challenges has been able to, how do you maintain that success? If you go in with a successful baseline, sometimes it's a challenge to continue with that success. And so that's one of the things that we've been looking on is how do we continue to get better? And I won't go through all the numbers there, but our providers are able to have some really impressive results. So we are constantly looking at how we evolve, how we get better, and how we continue to improve patient care. I think that's it for me. I think that was my last slide.
Yeah. All right.
Yes.
Tyler.
Good afternoon, everybody, and greetings from what has become a regional hotspot for COVID, unfortunately, here in Austin, Texas, and the surrounding metro areas, but glad to be with you. So I wanted to tell you a little bit about Austin Regional Clinic. So I've been with the organization for about just over 90 days now. I joined you most recently, and really just coincidentally that we're all from North Carolina, I believe, recently. So I'm joining you from Piedmont Healthcare, an independent medical group just north of Charlotte, North Carolina, and have been here in Austin, Texas with Austin Regional Clinic for about 90 days or so. So ARC was formed in 1980. It is a single tax ID integrated multi-specialty medical group. It started as a fully capitated commercial HMO partnership with Accou, actually, back in that time. It then iterated over time into a fee-for-service exclusive organization, and then just on the heels of the ACA started diversifying back into fee-for-service and value-based chassis where we find ourselves today. So I'm the Vice President of Population Health with the organization. Our department comprises about 500,000 unique lives that we would call ARCs in any given unique time frame. Of those, about 260,000 are going to be attributed to one of our value-based programs, of which there are about 28. Thanks. And you can see the organization is blanketed across the Austin metro, so really kind of a regional primary care presence with some multi-specialty lab and ancillary presence within the geography. We have a value-based contract tied to all of our fee-for-service contracts in the organization, and that's where we find about 2/3 again of our unique lives being attributed to those different vehicles. Next slide, please. And you know, we've got again a rich legacy here in Austin. We can go ahead and skip this to the next couple if you don't mind. Just to the pie chart would be good. Thanks. And so just to give you a sense of our value-based care portfolio, we actually participate predominantly through direct contracts with the payers and the medical group directly. We also have a host of other partnerships that are kind of interesting that I wanted to mention, one of which is a partnership similar to what Dr. Klausner was describing, where we are actually a participant as our tax ID in a variety of different clinically integrated networks convened with one of our core partners, which is Seton, an Ascension health system here, a nonprofit health system here in Austin. Through that vehicle, we've got about 54,000 lives, including our Medicare ACO, which is a Track E with about 17,000 lives attributed to our organization. The other interesting component is our Medicare Advantage work, which is burgeoning in the last couple of years. So that is an interesting partnership with an organization called Agilon, which is a private equity-backed joint ventured organization that we formed here to take full risk on Medicare Advantage populations and range anywhere from full capitation all the way to various degrees of up and downside risk for each of the Medicare parts. The other thing I just wanted to mention, because we're in a hot spot here in Austin, unfortunately, was just to give you a hot off the press update of where we are in terms of COVID prevalence and incidence. So as of this morning, with yesterday's data, we've got about 13,100 cases here in Travis County, which is kind of the nucleus of the Austin metro. That puts us at a 7-day moving average of new admissions of 75.1. And the interesting thing is, you know, in terms of the guidelines that public health officials are using to gauge when we would then put in place additional restrictions or go back to the restrictions where we were with only essential businesses being open, closing elective surgeries, those kinds of things. Their guideline for that was a 70 new admission 7-day rolling average. So we are now over that limit, and now there is some political discourse with the mayor, city council, local economic and business leaders really trying to determine now how are we trending in terms of hospitalizations, the answer to which is not great. And then when do we consider another shutdown? So they're looking at and anticipating another 35 or so day shutdown, trying to anticipate reducing the incidence of the disease so that we could look at reopening schools would be their intent come August and September.
Well, guys, Tyler, that's a great segue. Thank y'all for all giving that introduction of what you do and who you are and who you're representing. You know, our hope here is this is just us sitting around talking as in the Fireside vernacular of just going over some different things. And so we're going to leave this up for all of us to see. But if you have questions, please do not hesitate to send them in, and we'll try to get with them. And I'm going to start with a few questions. And I think the biggest question that we're all having right now is, you know, in North Carolina and Texas, as Tyler mentioned, you know, COVID is roaring and coming, and not just coming back, but it is sustaining itself. Our admissions are up substantially across the state. And so how is this, you know, we were going and now we're stopping. So how are your clinics, your services handling this? So I'll start with you, Dr. Klausner, with your different practices. From an operations standpoint, how are y'all handling the start and stops?
I think we're handling it the best we can. Is that a good answer?
Yeah, okay, so we'll go to the next one.
Basically, you take what the defense gives you, and I think, you know, we just evolve with it. And, you know, one things that we try to prioritize, so it's been tough, obviously, when it first hit, and really in March, you saw most of our clinics, the average visits go down over 50%. Where people were just trying to get a grasp on what was going on and prevent the surge and the catastrophic collapse of the healthcare system if we overwhelm everything. And that really went on for about 2 or 3 weeks. Now, the cool thing was that practices across the board were able to expedite implementation of the video visits literally overnight, you know, and there's been a lot of talk around that, how COVID-19 probably expedited by 5 or 10 years this inevitable evolution toward video visits and telemedicine. And then you look, you know, obviously we're a little bit behind some other countries, but you know, one of the things that stood out as you start looking at the situations in other countries is not only was COVID impacting patients, but we saw spikes in chronic disease, poor outcomes, mental health. And so really the idea from a primary care perspective is, you know, hey guys, you know, we don't make balloon animals for a living. Like, what we do is really important. And if we don't do what we're supposed to be doing in terms of working with our patients to keep them healthy, there's going to be serious, both short-term and long-term impacts of that. So I think one of the things that we're just prioritizing very simply is how do we continue to manage our patients, and how do we do that safely? And that means a lot of more video visits and telehealth capabilities when that is possible. And some patients we need to have come in the clinic. And when we do that, there's been a lot of work and effort around doing that as safely as possible, you know, putting in mechanisms and protocols and workflows, and we share those between all our 450 docs. There's a lot of great idea sharing, and even between the 3 hospital systems here, how do we best continue to serve our patients and our population with really the focus on what we've always done, chronic disease management. So how do we optimize diabetes? How do we optimize cardiac disease and prevent cancers and all the things that we tend to do in a primary care setting? But to also realize there's a short-term return on investment with this as well, right? So there's no better time than right now to make our patients as healthy as possible, just in case they do get exposed to COVID, they're going to be in optimal fighting shape to do well. And so, you know, there's a lot of proactive outreach to patients. Now is as good a time as ever to stop smoking, to start exercising, to eat right. And so really it's trying to see how we can optimize our patients' outcome, both short-term and long-term. And that's really, if you think about that financial impact, especially with a lot of smaller independent practices, and I think everyone has seen the literature around that. I mean, they're really in jeopardy financially as their average visits almost plummeted in half. You know, how do you sustain that? And there were some mechanisms and some loans and some governmental assistance programs that everyone took advantage of. But the best way to survive that is getting back to, you know, managing our patients and doing what we do and getting reimbursed for it, but doing it because that's how we're going to optimize patient outcomes and for the patients that we are managing. So, and regardless, it's going up and down. And right now, as Dr. Hoover is saying, we're seeing an uptick over the last couple of weeks in North Carolina. But regardless of how that evolves over the next couple of months, hopefully not years, staying focused on, all right, well, how do the best step moving forward to manage our patient population is what? And just being very strategic and smart and collaborative in how we decide that.
Yeah, I think that's you touched on the video visits and how it's been a huge leap forward. As a full-time pediatric surgeon, physical exam is really important, and in my line of work and trying to figure things out, and we've noticed that the lack of being able to touch a patient, just the two-dimensional video visit, we weren't trained in care. That's not how we trained in med school. That's not how we trained to practice. There was always some component of the physical interaction with the patient. And so, Matt, I'm going to give this to you, if you could take, is how has your ACO dealt with that specific lack of objective and subjective information in caring for your patients, in the sense of we still need to hit these quality numbers, we still have contracts we're at risk for, and we know that we need to be able to do this to provide better care, but we've taken a very important part of the provider-patient interaction off the table for a lot of our patients during this time?
Yeah, that's a good question. As soon as this started, of course, the ACO, since we have about 60% of our physician membership that's employed by the health system, and then 40% are independent, obviously, whenever the provider groups maybe are not doing well because elective procedures were essentially canceled, there was really no office visits going on, the ACO does really well. But the provider offices aren't, so that we always have that yin and yang relationship, and how do we manage that? We were also, like you said, we still need to meet all the quality measures, or else the ACO doesn't necessarily get paid. So how do you balance that? We've been surprised by the level of engagement from our members or patients. They aren't willing to go out of the home. We've really been surprised at the level that the payers have come to the table and made things somewhat easy for the providers in some ways. For example, for RAF, a lot of times or I think in all cases, they're requiring a face-to-face visit where you have to have them on the phone and you can see their face, versus just a telephone, which doesn't help our cause. So we've been applying pressure on the payers to change some of their rules. But for the patients, we've been surprised. They won't come out of their home, but they're more willing to answer the phone when our care management team calls, when our quality people call. They're willing to answer those questions. They're willing to receive a FOBT kit by mail and actually send that in so we can meet the measures that way. Our quality staff within the groups, they're willing for my team to go out and take a phone call about what they should potentially be doing with these patients. They've taken a new level of interest in all of these quality gaps because they might not be seeing the patient. So how can we leverage the quality-based contracts rather than the fee-for-service? So it's been interesting. There's definitely a struggle, but I think all of the groups are seeing a new way forward in value-based, because really the ACO is the ultimate hedge. for everything that they're doing, and it's, I mean, it's truly a value-based world that we live in, as much as we want to stay in the fee-for-service world.
So Tyler and Austin, where y'all may be, you know, taking a few steps back and shutting some things down even further. Let's take your diabetics, your patients that you're covering, that you have lots of diabetics that are difficult to control. Are y'all doing anything different than you were before? Are you doing more home visits? Are you ramping up to do, because people don't want to come out? Is there a way you're able to meet that high need, your congestive failure patients? Those patients that we know require a lot of effort, a lot of time, and can be very resource intense and cost a lot. But what specifically are y'all going to do differently if things shut down even further?
Yeah, such a good question, Dr. Hoover. And just as a quick data point, you know, we're tracking, as I'm sure everyone is on the call, you know, our overall gap closure rate. So, you know, we take, as I'm sure you do, all of our value-based contracts, distill them down to a core set of HEDIS measures, for example, with a common specification, and then, you know, track those at both an entity, contract, individual clinic, or individual NPI level, tie incentives in, et cetera. And of course, when you look at all of our measures side by side, I mean, it looks like my 401k curve, you know, right when the stock crashed. I mean, it just went to absolute zero. You know, even with things with a look back, like Matt was saying, like a colorectal cancer screening where we can look at innovative male, you know, methods like Cologuard or Fobit, all those things were active, and there was active patient outreach. But, you know, the first step for us, I think, that we learned in the initial wave that we will take with us into this next wave was navigating the psychology of fear, I think, of patients, and convincing them that our protocols in the clinics really do work. And I should mention, by the way, that we made a very early philosophical decision that under almost any circumstances, we were going to maintain our access provision across all 28 clinics, that after hours, weekends, holidays, you know, the only thing we didn't do were just new projects or clinic expansion during that time. And we did, of course, do some other expense reduction. But the one thing we maintained philosophically was we were not going to close the clinics. Hours are going to be the exact same, and we were going to maintain our access proposition. So if we were able to do that and navigate the psychology of fear, put in place meaningful protocols, that if we could, for all intents and purposes, get patients in the clinics, then we could keep them safe, and we could still do things like regular A1Cs or lab draws. So to do that, you know, the first thing we did was we looked across this metro and talked with other sister medical groups and saw that, you know, folks were grappling with this idea of workflow segmentation or segregation. So sometimes you saw, you know, clinics across the state close all of their clinics. That was one thing they tried, just as a means of, you know, PPE saving or as a means of expense reduction. We saw other clinics that would, you know, open certain geographic centers for, you know, COVID only clinics, or they would do, you know, clean and dirty type approaches. And then, you know, what we landed on was actually a clinic segregation within each. And, you know, each clinic is different, of course, where in one we may have just pediatrics, just FP and IM, et cetera. But, you know, what we did was put in a track A and B workflow where every patient that arrives is segmented based on a screening form, and in the near future to also include a temperature check. And, you know, if you've had, for example, close exposure with a known positive, or been to one of these hotspots, et cetera, or if you've run a fever of over 100, all these types of screening questions, then if that's affirmative, you're placed into track B, where you would go back to your car and then be roomed by an MA from that point when they're ready to bring you in and mask you. And then track A, if you answer negatively to any of those questions, then you can, you know, still follow universal masking and come in. And so what we've experienced in done that, and we've grown in our confidence of our protocol, is that with our employees who followed all these protocols, our internal positive rate has been less than 1%, while those in the community we've seen just in the last week of north of 15%. So, you know, what that tells us is that with the material level of testing in each cohort, you know, we're able to say that this really is a safe place to be. You know, and our providers actually say, and our outreach specialists, that it's actually safer, more in all intents and purposes, than you going to the grocery store. So the extent to which we can get you in, as long as diagnostics are being provided, whether that's lab or colonoscopies, et cetera, if those are occurring and we can do it in the clinic, we believe this is a safe place because we've had such a high level of discipline around those different protocols.
Yeah, and I would just kind of support what Tyler was saying. I love the way you said it's just got that psychology of fear. We realized very early on, and there's this great graph that shows this first wave of actually COVID-related deaths, and then a couple other waves, one related to worsening chronic disease because patients are afraid to come in and get the care that they need. One related to worsening acute issues such as appendicitis, and we're seeing this, and Dr. Hoover, I think you've seen this in the hospital as well. People coming in a couple of days after their heart attack because they were afraid to go to the ED because of their chest pain, or they're afraid to go to the emergency room because of their stomach pain. I had a patient about 5 weeks ago that was a diabetic and pretty severe diabetic ketoacidosis and nausea, vomiting, was hypotensive. And he didn't want to go to the emergency room because he was afraid of a theoretic COVID exposure, right? And so I had to convince him, look, I mean, your risk of diabetic ketoacidosis and the harms are so much more than a theoretic risk of COVID exposure. But I think that fear is really significant and pathologic, and fear and confusion and everything. So that is absolutely a prerequisite to being able to do what we do in terms of managing patients' health, is getting around that. And we've adopted a lot of what Tyler's talking about as well in terms of patient-facing material and trying to get them. I've been, honestly, maybe I shouldn't have been, I've been surprised at just the level of fear patients had to come out of their house. And some of that is justified, but you can see very quickly how that can become very detrimental to their health and all the outcomes that we're increasingly being held accountable to.
Do you, Matt, working with your specialist, and Brian and Tyler, forgive me, I don't know this in your group, but if, with WKCC and your high value specialists, I know you have, the ACO does not have any control, so to speak, or of how those individual specialists are running their offices, and so you can have a lot of different types of protocols and procedures that patients are having to navigate depending on where they're going. It's not a uniform, except as Tyler's saying, they may not have that. They may have shut down some offices here or shut down hours. Are you worried about your network leakage, and that you're more vulnerable to the normal lines of communication you would have, or the normal cooperation, participation you would have with your specialist, that those are breaking down, that they're not as reliable, and that you're going to see more leakage from your captured lives over this next 6 months? So I'll start with Matt and we'll go across the board.
Yeah, so I would say that we're always worried about network leakage. And on the map that I showed you, anytime that those cases go out from our area to one of the academic medical centers, both THN, we lose based on the DRG difference between seeing an academic medical center versus staying at home, but also our health system loses, and we call it the double whammy, because they're not getting the revenue because they're gone, and of course THN loses, but also we don't know the downstream ramifications of that. If they're going out of network, do they stay out of network? Do their families stay out of network? The next generation of their families stay out of network? So we are very, very concerned about that. And what's interesting with COVID is I would actually expect less care to go out of network, just because most elective procedures are stopping, and the only things that would really go out are those cases that really need the high level of care. So in the short term, I predict that number to go down, but as pent up demand hits, I foresee a spike. For us, we have about a 20% leakage rate. And if we could recapture all of that, it's probably about $68 million. And we know that we're never going to recapture the full 20%, but I think that we could get year over year 1 to 2% of that conservatively. And so
yeah,
that's
like
why
what's the specific way that you're knocking that number down? Like, what do you think has been most effective? And especially if you say there's less going out now, so maybe this is the opportunity we got a little more time, we got a little more contained networks. So how do you, if there is not, how do you make those connections even stronger so that when the things are released, so to speak, they're still coming your way?
Yeah. So I think one of the nice things about the ACO is that we are a community of providers and administrators and staff. And even this week, we set up a general surgery council to review cases that my specialty medical director and I went through for a couple of months. We literally reviewed 60 cases and why those transferred happened from the ED department from one of the fringe hospitals. And we just need to understand what the relationship issues are between that fringe hospital and the central hospital, and going through those to understand them. We obviously have the referral management software that we've incorporated into all of our primary care sites and specialty sites. We have the data now to understand where those patients are leaking to from what sites. We obviously have the claims and analytics behind that too. So really, it's just a matter of going out to those groups, helping them understand, for sure, helping them understand that we are a value-based organization. And if you're sending those patients to a higher DRG facility, you're literally just taking money out of your pocket. Now, that's assuming that all quality is the same. But having the conversation with our physician colleagues, that's really the first place to start.
Tyler, are y'all able to get to be that transparent with your practices about where your leakage is and how they can impact that?
Sorry, I was muted. So it's been interesting for me, transitioning from one independent medical group to another. And I think what you're hitting at, Dr. Hoover, is spot on, that it sort of is contingent on the culture of the organization and the priority they place on that as a key performance indicator. So, I think ARC does a lot of macro level, things related to referral management, and then just driving home the importance of keeping, available services in-house, and then getting to the why of why it's important. To Matt's point, for example, we see if you have a predominance of your care with ARC on the commercial side, it's going to be between, $20 and $40 PMPM lower than if they had it otherwise, because the care is coordinated to an extent with a single medical record, emphasis on prevention, all of those types of things. And then comparing that to an organization like Piedmont, where I came from in North Carolina, and again, just different dynamics. In that organization, we were actually using claims data, to identify, first of all, who is our network and who is not, to Matt's point. Then we can take a look at, within that data, what services do we actually have in network and which don't we, so you can come up with an accurate denominator of what is fair to assess that could come in network versus what can't. And then once you go through that exercise, sitting down in our what we called our stat card meetings, where we just look at the ball card for every NPI level within a clinic, and then we get together with each clinic to go over their clinic level and NPI level stats on that KPI. We can then say, okay, we've got an outlier and here's our goal. And then to Matt's point, here's each of the dollars within this contract that are associated with every, in-network encounter of a certain type, for example. And what was interesting in those was, we found that not framing that conversation punitively was to our benefit, obviously. So it's not a gotcha, why did these referrals go out of network conversation. It was a lot more of a, are there things that you as a provider are not receiving from your colleagues or from that side of care that's causing you to refer in that way? Or are there things that we as a clinically integrated community can do to arm you with tools, processes, information or relationship building to make sure that we can earn your business back. And that was a really more effective conversation to dive into the data, again, identify specifically, okay, it looks like, this provider they're leaking out mostly orthopedics. Why is that? Let's look at the data at a very specific level together and determine what we can do about it. And that was generally more effective.
Are y'all able to use your quality metrics to drive expanding capacity with your subspecialist, or with your, to go to your cardiologist or your orthopedic surgeons and say, this is this is your wait times to get in, this is your readmission rates, any of your quality metrics, to say, hey, we need more service or we need better service. Are you able to do that with your subspecialists with this data that you achieve, that you have? Go down the line, Matt, yes or no? Just a quick answer, I guess.
It's not exactly as easy as a yes or no. With the specialist, with some software, we have been able to increase our access scores, which has always been a problem for us through CAPS and HOS. So in that way, yes, but other quality metrics, we don't take those to our specialty physicians just because they're not the PCP. They're not going to order the mammogram, those kind of things. But access, that has increased with things that we've done.
Brian?
Yeah, same as Matt's answer. We track access and communication back to the providers. We always prioritize communication / collaboration as the lowest hanging fruit from a pop health perspective, especially if you think from a primary care specialist interface. The main issues that we've had historically that has led to inefficiency and high cost is just lack of coordination and collaboration. So we prioritize those, but we don't drill down to the level of the individual HEDIS measures.
Tyler?
I would say during the pandemic, we've not had an issue with specialist access. So it's been the best access we've ever experienced, actually. No surprise there. So that has become more of a priority for the specialist to be actively engaging with their referring sources during this time to make sure that, when electives were shut down, then they went to 110% of pre-COVID production. And then as we're anticipating electives shutting down again, this becomes more important. So that's been our experience here in this market.
One of the good things that I think we've done well is we when, let's say, a GI doc is repeating a colonoscopy that was normal, completely normal, no family history, and they repeat it 5 years instead of 10 years against guidelines, like they will contact our operational team. We'll outreach to the doctor and say, hey, did you realize that your primary care docs, your referral base, is being held accountable for these measures and for your performance, not just for the performance in the clinic, but for your performance as well. We have had a lot of good success with urgent care centers as well in terms of pharyngitis testing or antibiotics for URIs for kids. And when and if a provider sees that there's a certain primary care doc sees that an urgent care provider is prescribing antibiotics for URIs or something like that, just outreaching to that provider and saying, hey, did you know that because you did that with one of their urgent care patients, they get dinged from a quality perspective? And in the primary care referral groups that that you're working with, they're paying attention to these things and they're realizing that. And I think on a provider perspective, when you get that information out and you remind providers about this is a new world that we're living with, and it's a new world that we as primary cares are ultimately being held accountable for your performance. I think that changes behavior. And I keep telling specialists the referrals are not going to be coming anymore from your golf partners or because your kids go to school together. You have doctors who are really paying attention to stuff, and they're going to refer based on how well you take care of patients. Are you avoiding unnecessary procedures or surgeries? Are you performing high quality care? That truly is, and that's where the sustainability of the model comes in. It took a couple of years to get there, but that really is what our primary care base is focused on. And when and if the specialists realize that, that's going to change behavior, which is going to benefit everybody involved, including the patient, including the ACOs from a performance perspective.
And I'll add, I can add real quick to that. In 2019, well, first I'll back up. If anybody out there has a wildly successful specialty incentive plan, please email me immediately, because it's been incredibly hard for us. And every conference that I've been to, every person, every executive, et cetera, that I've talked to, it's a hard thing to do. We've had multiple variations of an incentive plan for specialists over the years. Last year, we largely focused on clinical care variation, and we asked the specialists to pick a project to reduce clinical care variation. The next year, we really dubbed it the year of the elimination of low value care. I came from a specialty office, and I could tell you right now, we had 3 docs in there. One would give care away, one was in the middle, and one would tell me, order as much as you possibly can, get any kind of test that we can get in here to raise our revenue. I don't care what it is, and I'll sign off on it. So obviously, we all know there's things that can be eliminated. So this year has really given the specialists a chance to work on clinical care variation and submit projects to us that we sort of grade and give them feedback, and then they work on throughout the year. Because Dr. Klausner, to your point, PCPs now are realizing that they're really the CEO of $1 million worth of healthcare spend for their patient panel. So where they send those patients, given they have a choice, for us, urology, we just don't. There's really one group. Matters. It takes money out of their pocket, assuming all the quality is the same or some are better. So we're getting to the point where we can hand out provider scorecards to our PCPs and give them feedback on who's doing what.
Yeah, and a quick follow-up, I totally agree with you. I don't think there is a good specialist incentive plan out there, because there just isn't. I think the greatest specialist incentive plan in value-based care is increased market share after demonstrating your value. Increase market share in what truly still is a fee-for-service world, and that's going to be greater than anything. I mean, so whether you give a couple $1,000s here or there, the big thing that and this might be unique to our market, where you have a lot of competition, a lot of really good doctors, is making people realize. And we do this every year. We bring in all our high-value specialists, and we talk about, hey, this is what's going on in value-based care, and did you know that your future, your referral rate really depends on how you perform. And hey, cardiologist who orders an echocardiogram every 6 months for the hell of it, like that, people are not going to tolerate that anymore. Not only the insurance company, but the primary care doc, because you're dinging them. So I don't know if you're ever going to get a good value-based care incentive plan for specialists, but I think you may not even need one. What you need to demonstrate is the way they get market share is demonstration of value.
Gotcha. So I think that you're absolutely right, Brian, in that with your high value specialist, because, your specialist, it is fee for service. As you said, I'm a pediatric surgeon, and it's fee for service for us. And so it's in that regards, the reward for being a good citizen is more patients. Yeah. And that's much more than, like you say, a $500, quarterly thing or something that in that regards. We're getting close to the hour, and I want to get some, if there's any questions that have come in from the audience, I want to get to those. But I do want to ask one more question real quickly, and that is, especially in this climate of fear, we're struggling to get patients to come in. It's costing us more to care for them just because of PPE, social distancing. Our panels maybe not be as full because you have to allow for more time, all those things. Are you still looking at expanding your capabilities and growing your footprint, or are you we're just going to wait and see what happens those next 6 months, and then we'll get back to our expansion? So Tyler, just with y'all, and then go to Brian and Matt real quickly, and then I'd like to get some questions.
Sure. So I think the short answer is yes. And the challenge with an independent medical group, as I'm sure everyone knows, is, you know, these are not organizations with a history of retained earnings that, you know, we can drive capital into expansion on a regular basis, maybe, you know, like a health system with a lot of days cash to weather a storm like this. That notwithstanding, you know, when we, for example, per the discussion a minute ago, when we stratify an external specialty like, say, nephrology and dialysis for our high-spend ESRD patients and CKD patients, you know, we very quickly will find that, for example, within a small group or a large group where our folks go, there's always one or two really high-value specialists within that group. We'll then approach that group, show them data, work with them in a JOC structure over time to improve their value proposition together. However, you know, sometimes that value proposition doesn't change, or there's not commitment, or there aren't reasonable incentives or collaboration for any number of reasons. And so that's when you see a medical group like ours take kind of a Kaiser strategy where, you know, we're going to have to bring it in-house or build that specialty in-house, you know, to get the value proposition that we expect to perform on these contracts. So, you know, the impetus is high, you know, for us to continue to do that over time. So absolutely.
Yeah. I think administratively, you're always looking at growth opportunities. I think clinically, honestly, most of our focus has been, and probably will be for the next couple of months, just kind of trying to adjust into the new norm and how do we do that and optimize patient outcomes? How do we best serve our patients right now? You know, we're seeing spikes of mental illness, especially within our patient populations. We're seeing worsening chronic disease. So we're seeing a lot of these things that are spiking up that we're just trying to get a hold of for the next couple of months. I think that's really our operational focus right now.
So Brian, if y'all have, if you're seeing a chronic disease spiking, or, you know, that's becoming more of a problem, do you also have task force up? Do you say, okay, these 3 doctors have an interest in it, let them sort of lead the group and give some best practices and some guidelines? And
yeah, it's going to sound arrogant, but it's not. Our providers just, and historically this has always been the case, we just have really, really good providers. So part of our strategy is just bringing in tools and resources and then telling them about the tools and resources so they can utilize them. So from an administrative perspective, it's going out and making relationships with behavioral health providers, building up the different provider base that we can refer to, and bringing in different analytics and risk scores. And we meet every quarter, say, hey guys, these are the current tools and resources. This is a best practice. This is somebody who's used this tool and this has been their result. So it's really trying to identify those, educate our providers, and then let them utilize them. So we do a lot of best practice sharing, but a lot of our providers don't have a ton of time for work groups right now. So we'll do best practices and try to develop these and get them out to our providers.
Great. Matt?
So the short answer is yes. Dr. Klausner, I don't foresee us coming into your network and stealing all your patients, so rest assured. But there's an incredible amount of unattributed members that are attached to the plans. So one thing that we're really looking at is how do we get those members attributed, because we're probably taking care of them anyways. That's number one. Number two is expansion beyond the.
What's one way that y'all do that? I mean, how do you? I mean, what do you? What's a like your? What do you do? How do you get that attributed live to? How do you get that live attributed to you?
Yeah, so we need to flip them to one of the MA plans that we're contracted with, and it's not a flip from. For example, we're contracted with UHC, we're contracted with Humana. We don't want to flip them from UHC to Humana because that doesn't give us any growth. We want to get true growth. So we've considered putting, or we are putting agents in different areas for member outreach so that they can explain the benefits of the plan, explain the benefits of MA, because we really think that MA is the plan that we can do the most with. So those kind of things.
Gotcha. All right, Garrett, we got about 5 minutes left. Are there any pressing questions? Or?
Yeah. So, and I realize, everybody, that we're going a little bit long today, but there's a lot obviously to cover. Some really good stuff. So, just as a reminder, this is all going to be recorded. So if you have to jump off, you can certainly do that, and I will send you a link to the recording afterwards. But I did want to hit a couple of these questions. So if we go a couple minutes over, that might end up happening. We did have a number of questions that came in, and you can continue to contribute those questions. And if you have any of the specific panelists that you want to address, go ahead and specify that in the questions that you ask. But a couple that came through, starting in no particular order here. The first one, it says Marshfield Clinic, a winner in the PGP group practice model from 15 years ago, that was the precursor to MSSP, indicates about a third of all acute admissions can be accommodated in the hospital at home. How are each of your entities addressing the transition to this new mode of delivery and business model?
So this is, I can jump on really quick. This is an interesting opportunity, and we have a Thursday meeting where we meet with Duke, UNC, and Wake Med in the county and DHHS, and we talk around COVID-19 strategies. One thing that Atrium actually did really well in North Carolina is this hospital at home model. So we all started looking at this in early March as a way to offload some of our bed pressure from COVID-19. And I think that stat is absolutely right. And so there are a lot of patients, whether it be COVID, cellulitis, CHF, whatever it is, that can be managed at home. So I think our hospital system, as well as other local ones, are rapidly developing these, studying these. To date, we've had 25 people in a hospital at your home model that we started about a month and a half ago. So a ton of potential. Again, when life gives you lemons, make lemonade. So yes, a response to COVID-19, but is that something that we can leverage after COVID-19 into expanding population health efforts?
Yeah, the other thing I would say is, we were looking, Dr. Klausner, yesterday, even at, again, our ESRD spend, especially as some folks are probably aware with Medicare Advantage becoming enrollment eligible for existing ESRD members next year. This becomes of a heightened priority. We were talking with some innovative nephrology groups and ESCO ACOs in recent history that have done home-based dialysis, and that's been a really successful model, for them, with frequent interactions with a nephrologist or care team member and doing that at home to save costs. The other thing we're constantly doing is just trying to think outside the box about home-based care management extensions of our care management team. So ours is an embedded and telephonic model, whether it's chronic condition management or transitions respectively. And what we're trying to grapple with today is we do some home visits for certain segments where there are incentives to do that with the payers, but how do we expand that writ large to make sure that, whether it's a patient experiencing an exacerbation and it's like an ARC branded, paramedic with a basic formulary responding to that to, for example, be able to administer antibiotics or Lasix, for example, for a CHF exacerbation, or it's just a routine follow-up with a social worker or a nurse. How do we get into their home and really see the efficacy of that overall program go up too? So I know that's something we're just grappling with constantly.
Right. And I know Atrium was using a cohort of their own hospitalists, for the inpatient hospitalists to run this. Brian, are y'all considering, if this expansion goes well, to hiring your own, WKCC-based hospitalist people that would be running the in-home hospitalist patients?
Yeah, there's two different approaches. One, you can put it into the community doc, so I could just manage my own patients at home, and I think there's certain benefits to that versus having it centralized, which two of the local models have done. So I think it's still yet to be determined, but it is kind of its own specialty, right? Like you can imagine same thing from a hospitalist perspective is there's some benefit in having them do, that's all that they do as well, as long as you can communicate really well, especially across the shared EMR. It's a special skill to be able to go in the home and provide this home type of care. So I would imagine a lot of models, still yet to be determined. We use Dr. Watson as he's kind of our home health specialist guy who will come in and do this. But I think that's yet to be determined. I imagine most programs will probably use a centralized team for this.
Jared, you have another question you want to get to?
Yeah, very good. Yeah, the next question here is and you kind of touched on this earlier, but about it says, are you finding that patients are fearful of coming into the clinics for an appointment? And I think that you answered that with a yes. But another follow-up question to that is, do you require masks and social distancing in the hospital environment?
Yes.
So I think all the hospitals around here for sure are doing that. They're it's state law and it's required. I think that we have to be careful that we are not speaking out both sides of our mouth when we say it's safe to come in, but you can only bring one family member. You know, it's a little bit like, well, why can't I need to bring two family members? So I think we have to be careful with the rules that we think are put in place, that they don't make the fear factor worse, you know. And so, you know, and it also goes to our staff, but if we're putting them in a waiting room, we want them sitting 6 feet apart. But we also know that if they're wearing masks and they're sitting 6 feet apart and everybody's wearing masks, it is safe. And I think that is a key thing that we as providers, I'll speak a little bit of, have to be engaged with, is telling people it's okay if you're doing these things, you're safe. And, you know, it's, as Brian said, you know, being DKA is not a good thing. You're not going to get, you know, you're better off getting that cared for than the theoretical fear of COVID.
In terms of protocol, I'm curious with the physicians on the call, are you all concerned about protocol catching up with, you know, some of the new observations about the virus being airborne? And I mean, do you think that will impact masking protocol or, you know, eyewear protocol or anything of that nature in the near future?
I mean, I think it's hard to say. I think everything is different in July than it was in May, and I'm sure it's going to be different in September. As it's hard to practice evidence-based medicine in something that's only 4 months old. So I don't see a dramatic change, but who knows what study will come out next with some experience. So I think it's all to be determined. I mean, I think a lot of the recent literature around the disease prevention with masks are pretty solid, but I'm sure everything will continue to evolve on a week-by-week basis.
And you know, Tyler, to your point earlier, you know, we do have a few months history of doing this from a standpoint of just as in your clinic and our clinic, and I'm sure at Matt's as well, the incidence of our staff becoming infected with COVID from patients is very, very low. And you have to look at why that's occurring. And it's because of the screening, but it's also because that we are wearing masks, we are doing universal precautions. So they do work. So I think, you know, they've come out with some new guidelines about masking and things like that for aerosolized procedures, and I think that's reasonable. But I do think that just the masking and the 6 feet and the masking is definitely sufficient, probably, for the majority of instances.
Yeah, and we saw some pretty reassuring data. We had, you know, in North Carolina, we had 124, I believe, nursing home outbreaks. And an outbreak, I think, is 1 or 2 cases, but 54 of those were just staff members. So an outbreak is either staff or patient. In those 54, none was transmitted to the patient. So basically what that means is all the protocols that the nursing homes have put in place around masks and social distancing, even when you had infected staff, it didn't get transmitted to the patient. So there's little data points like that suggest that a lot of what we're doing is working. I'm sure there's going to be, evolving recommendations to optimize what we're doing, but the social distancing and masks seems to be at the core of it.
Yeah, you want to do just one more question? I think we need to let our panelists go.
Yeah, absolutely. Just let's do one last follow-up question. And again, I apologize we're going long, but this is some really good stuff. And again, for those of you who need to jump off, you can do so. I'll send you a link to the recording so you can see the remainder of it. But the last question here before we close out is, how are your organizations assisting independent practices with telehealth expansion?
I can start. Right when this started, obviously there was a need to inform all of the groups what the standards were, what was going on with the payers. They seemingly changed every minute from what I could tell. So immediately we fast-tracked an app with the Android store and the Apple store. We got one going within 7 days, and every time something changed, we put it on the app. It gave everybody alerts. We offered vendors for telehealth if the groups didn't have it. Sent the information, arranged phone calls, all of that kind of stuff, specifically for telehealth.
Yeah, it kind of happened here quickly, especially in mid-March when there was a federal loosening of the HIPAA regulations. We had great payer support led by Blue Cross very early on that were paying at par for video visits, and that everyone had kind of already looked at different programs or platforms. So all our independent docs, and again, we're 80–90% independent, quickly were able to stand up their own. So it wasn't one platform across the system. All were able to develop it using their whatever they thought worked best for them.
And my response somewhat hits this question. The one thing I'll say that I'm sure everyone has been frustrated by has been, the Medicare position with the 1135 waiver affecting payment parity and RAF submission. How that affected then audio visual, and then how you compare and contrast that in each of your individual payer matrices for all your commercial payers is mind-boggling. And as Matt said, for us, what that meant was just enabling certain avenues of telemedicine within those regulatory frameworks, and then making sure folks were educated about it. So for us, as a single tax ID independent medical group, we were primarily doing most of our telehealth initiation through the patient portal in Epic. And then, what we had done some years ago in anticipation of this was also built a third-party independent proprietary system called EMD Access, where we have a pool of ARC physicians that are either FP&IM or pediatrics on-call 365 for either ARC PCP relationship or external to ARC either payer, employer groups, or individuals. And so we also offer that to the community and then to purchasers so that they have access to ARC physicians, whether or not they have an ARC primary care or physician relationship as well.
Right.
The only thing that I would add to that is early on, a lot of providers were a little skeptical of jumping on their iPhone and talking with patients through FaceTime. But that's literally the first step to wet their feet. So if any of you are having problems with that kind of stuff, just encourage them to just try it one time and then convert them to some sort of a WebEx platform. And even me, I committed this last week to always have my video up in meetings because our culture, or at least our culture, is not to have the video up. We're not a work from home company, but I think it helps with the interaction with employees, it helps your leadership, and it helps all that stuff. So I would just encourage it if you need to do that.
Great.
Well, once again, thank y'all so much for your time. We appreciate. We know we've gone over here. I've learned a lot and listened from these guys, and like I said, we're very happy at Proficient Health to be able to support this and provide this for y'all. And if your organization is looking at improving the communication behind the care, from secure texting, from referral management to data management, we'd love to have a conversation with you about that. So thanks again for your participation.
Great. Thank you, gentlemen, so much for spending your time. And Dr. Klausner had to hop off, actually. But I think this is a really, really great discussion that we've had today. And in conclusion, wanted to let you all know, again, this is being recorded, and I'm going to email all of you a link afterwards to that recording. So that'll come sometime today. And lastly, I'd like to encourage you to visit the Proficient Health exhibit booth at ACO Exhibit Hall. And this is where you will be able to connect with them and their team. You can see that on the screen here. This is what that looks like if you go to acoexhibithall.com. And this is also where the recording will be housed. So you'll have that in the archive, and you can download the slides and whatnot also in the reference library there. Lastly, if you have any specific questions for any of our panelists or the Proficient team, Their contact information, we're going to actually funnel it through Dr. Hoover. So his contact information is here on this last slide. And so feel free to reach out to him, and he will be happy to send that where it needs be. And we'll be happy to follow up with you for further discussion as well. Let us know if you have any feedback from today. You can email me directly. And I would love to hear if you liked this, if you want to see more of this, if you want to see more of these guys specifically, and maybe to do another round or whatnot, let me know. But thank you all for attending. I really found this informative. Hope you have a great rest of your day. Stay safe.
Bye-bye. Thank y'all.